speaker in the session, Dr. Ruchika Rani. She is an assistant professor in the College of Nursing, AIMS Rishikesh.
A very good morning to all present here. Um, my topic, the title of my study is a randomized control trial to assess the impact of a nurse-led pre-chemotherapy education program on quality of life and psychological distress among patients with breast cancer in selected hospitals of Uttarakhand. So as we know, breast cancer after beating the other cancer has grabbed the top rank in incidence and second rank in terms of mortality rate. Even it has surpassed the lung cancer also. In Uttarakhand, the same situation is that the most prevalent cases among females are the breast cancer, followed by CA cervix and CA ovary. For the novice patients who were recently diagnosed with breast cancer, specifically the first year after the diagnosis, it's a very challenging for them, including all the domains of life, social, psychological, physical, and spiritual. This nurse-led education, it can be an important intervention for the patients who are newly diagnosed with cancer and overwhelmed with their emotions. So the objectives of our study is to assess the baseline quality of life and psychological distress among patients with breast cancer undergoing chemotherapy. And second objective is to assess the effectiveness of this intervention, nurse-led pre-chemotherapy education program on quality of life and psychological distress among patients. The delimitations of the study was it was delimited to patients with the age group of 18 to 70 years. Patients received chemotherapy for the first time, newly diagnosed patients receiving 4 cycles of chemotherapy, patients receiving chemotherapy in the daycare or oncology wards, and single time administration of this education program along with 3 times telephonically follow-up with regular intervals after 1 week of chemotherapy. The research methodology, the trial design was prospective, randomized, controlled, parallel group design, single-centric study. The target population, breast cancer receiving chemotherapy, and the period of data collection was from August 2018 to March 2021. The research setting, OPD, wards, daycare centers in AIMS Rishikesh. Purposive sampling technique was used. Total sample size was 80 and it was registered under CTRA number. The eligibility criteria was the patients who were included as per the criteria, newly diagnosed patients with breast cancer getting chemotherapy for the first time and having normal hematopoietic, hepatic, renal, cardiac and lung functions at the enrollment. Performance status as observed by the ECOG scores 0 to 2. Patients who can read and understand Hindi or English language willing to participate and between 18 to 70 years of age. Exclusion criteria, the participants who had clinical evidence of intellectual impairment or psychiatric conditions had already received chemotherapy before in the study hospital or any other hospital. They were receiving concurrent chemo and radiation therapy and were at the terminal stage of illness. These were the tools for the personal profile, socio-demographic profile, clinical and obstetric profile. For the quality of life, the European Organization of Research Treatment of Cancer Quality of Life questionnaire, that is EORTC QLQ C30 and QLQ BR23 was used. For the psychological distress, HADS, that is hospital anxiety and depression scale was used. Even for the laboratory diagnosis, CBC RFT as a hematological profile was assessed. The primary outcome was quality of life among patients. The data related to quality of life was obtained at 2 points, before initiating the first cycle and then at the 4th cycle of chemotherapy. For the secondary outcome, psychological distress, it was assessed at 2 points, similarly at the baseline and after at the 4th chemotherapy cycles. This was the data collection flowchart. First of all, we have collected the baseline data of the patients. Then before starting the chemotherapy, we were educating the patients regarding what is chemotherapy, how it can affect, what could be the side effects of chemotherapy, and how to tackle the side effects at home by using some home remedies. So it was given in the booklet. So we have arranged a booklet where all these how to manage the symptoms at home, it was given. And for the psychological distress, we are also providing like Yoga Nidra therapy. We were telling them to how to perform this Yoga Nidra therapy. So afterwards, just this program education booklet was given before the starting of chemotherapy. But as per the chemotherapy has been started, after 1 week of chemotherapy, we were doing the follow-up with the patients, but by telephonically. So we were asking them any symptoms they are experiencing or any side effects they are having. So we were encouraging them to adhere to the guidelines which we are providing in the booklet. Similarly, same if we are continuing till the 4th cycles of chemotherapy. This was the randomization. We have used allocation sequence was produced online by sealedandwhelp.com, and we have allocated in 2 groups by using the block randomization manner with the block size of 4, and predetermined sequence were written on paper slip and kept in the sealed opaque envelopes. And blinding, it was an open trial study, so patients and researcher allocated to experimental and control group, they were aware to the allocated arms. So this was consort chart. We have approached 125 patients. Out of them, 27 were excluded as 5 patients declined, and some other, for the other reasons, 22 have also excluded. Then afterwards, after screening, as we have assessed for the eligibility, 17 were not meeting the criteria, then randomized for 81 patients. Allocations, so 40 patients were allocated to intervention and 41 for the control group. After the follow-up, in the experimental group there was no loss to follow-up, but in the control group there one patient has lost during the follow-up time, and 40 patients in the both control and experimental group for the analysis. So as the data tells that, if we'll see the just data, it will tell that table 1 comparison of socio-demographic profile in experimental control group. The mean age was almost similar. It was 47 among the female patients. Maximum patients were married, they were not working, and vegetarian. In the clinical profile, we have seen that the most of the patients they are approaching to us, nearly half of the patients, they were on the stage 3, and the hormonal receptor status, like they were having ER/PR positive and HER2/neu negative cases, and all of them they are getting AC chemotherapy, that is adriamycin and cyclophosphamide, and most of the patients they were receiving 4 cycles of chemotherapy. So comparison of obstetric profile, we have seen that in the breast cancer patient, in the experimental group the mean age was 21, and in the control group it was 19 years. So there was slight difference between these age group. Similarly, at age of menarche, it is similar in both experimental group and control group. It was 14 years of age. Duration of breastfeeding was also 24 years and 26 months. Sorry, it was 24 months to 26 months, that is 2 years. Duration between marriage and first child, it was 12 months, within the 1 year we can say, and number of children born ranging from 2 to it was in the experimental it was 0 to 7, and in control 0 to 6. Age of menopause also, it is that is mean age is 50 years. If we'll see the difference between the quality of life, as we can see the effectiveness, during the baseline the mean quality of life was 67 in experimental and control group. It was similar in both groups, and if we'll see at the 4th cycle of chemotherapy, there was a significantly difference between the quality of life, global health status. We can see that in the base from the experimental to at the 4th cycle of chemotherapy in the experimental group, there was mean difference was -16, and in the control it was -25. There is a significant change in the global health status. So there is a changes in the mean score as per the quality of life. We'll see that mean within the group, the global health status has declined in both experimental and control group, but the decline, the difference between the decline, if you can see that it was -7 in the experimental group, and in the control it is -23. The global health status has been declined too much in the control group as compared to experimental group. However, we can deny that global health status has also been declined in experimental group also. Similarly, in the functional scale, we can see that the physical functioning has been declined in both groups, but as compared to, if we'll see in the between group, there is a, like in the experiment it is -6.83, and in the control it is -35. There's the largest difference. Similarly, the other role functioning, emotional functioning, cognitive, they has been improved as compared to the control group, but other symptoms we can see that the symptom has been less noticed in experimental group as compared to the control group. This is according to quality of life as per the EORTC QLQ BR23. Similarly, these all in the experimental group, the body image, sexual functioning, sexual enjoyment, it has been declined, but as compared to the control group, there is a less observed changes. Comparison of psychological distress among patients at baseline. we can see that there is a significant difference in the anxiety in the from the baseline to fourth cycle of chemotherapy. There is a significant difference, but in the depression at the fourth cycle of chemotherapy, we can see in the experimental to control group there is a significant difference in depression also. So in the present study, the mean global health score was significantly higher in the experimental group as compared to the control group at fourth cycle of chemotherapy. Similar findings we have noticed in the literature. Recommendation: a longitudinal study can be planned further. We can see before and during and after the completion of chemotherapy. Even we can also plan for the mixed method study and assess the cost effectiveness of this program in terms of hospital visits and emergency admissions. The study was limited to single centric, which may restrict the broad generalization of findings. The conclusion in the study concluded that the nurse-led pre-chemotherapy education program, including telephonically follow-up with patients in experimental group, had revealed a significant difference in their quality of life and distress. Increased awareness of patient towards disease and treatment and their preparation towards upcoming side effects, their management at home will make their life free from anxiety and depression, which can positively affect their quality of life. Thank you so much.